My dear students, silent. We were talking last time common causes of hearing loss, how we should understand ear, its functions, what are the common causes. Today we are likely to go through very common cause that leads to hearing loss and many complications. The sign of our betterment of our own family. You should behave very nicely at home, wake up very early, and smile round the clock so that people feel that now you're one of the best part of your family. If you are well acknowledged at home, then you're the best civilized person for the society.
Excuse me, sir.
We
Okay.
believe that you will be enjoying a very good health. Today we are likely to go through the most common cause of hearing loss, that is acute suppurative otitis media, infection inside the middle ear. Infection inside the middle ear by the pus-forming organisms is called acute suppurative otitis media. Common organisms that leads to acute suppurative otitis media are H. influenzae, Haemophilus influenzae is a bacteria. Second common bacteria is pneumococcus, Streptococcus pneumoniae. So each of us has to know a lot about H. influenzae and pneumococcus. Haemophilus influenzae, as you recall your fourth year knowledge of bacteriology, H. influenzae is a germ of babies. It's extremely common in initial few years of life. In children, H. influenzae is most common. Especially its type 2 strain is more notorious. H. influenzae type B. There are good vaccines available. Those children who will be vaccinated nicely against H. influenzae, their infection ratio of the ears and nose will be extremely low. So Hib vaccine is nicely advocated. Cleanliness, bottle feeding avoidance, clean water, very good hygiene, and Hib vaccine can change towards betterment. Second common cause that leads to hearing loss is chronic suppurative otitis media. When acute phase stays for many weeks, few months, it will end up with chronic suppurative otitis media. The germs totally change now, not H. influenzae and pneumococcus, it's gram-negative bacilli and gram-positive cocci. Gram-negative bacilli and gram-positive cocci. These gram-negative bacilli are usually coliform germs, and number one is, we should remember at least 2 or 3 names: Pseudomonas aeruginosa, Pseudomonas pyocyneus, and Klebsiella. Various even E. coli sometime. And we should remember few names of bacteroides, gram-negative bacilli, and CSM is 2 different types. Tuber-tympanic, that is always infection starts from nose or throat, end up with the ear infection. When the infection is in upper respiratory tract, in the nose or paranasal sinuses or throat, and it ends up inside our middle ear. Whenever there is nose infection, whenever there is throat infection, there is start of ear ache and ear discharge. It's a tubotympanic in a classical way. If you treat the source of infection inside the nose or throat, things will be absolutely fine. Usually a source, nidus of infection is in the nose and throat. It's a tubotympanic. Through eustachian tube, infection is transmitted again and again towards the middle ear. That's the basic fault actually. Its second variety is very notorious. We should remember it because this thing leads to a lot of issues nowadays. Eticoenteral. Here the disease is independent of any source, mostly in the throat or nose. Here it is absolutely independent from all its direct transmission. It's quite often, most commonly, because of a different disease in the upper part of the middle ear or in the antrum. Antrum is the posterior most part of the middle ear, posterior most in the mastoid process. Etiquental disease many a times end up with a very serious tumor-like situation that is called cholesteatoma. Cholesteatoma is tumor-like situation. It's a malignant behavior, but it's a benign tumor. It's a benign tumor. It's a skin envelope inside the middle ear that continues grows. It's having eroding activity, highly invasive activity. Locally, erosion is always very common. Whatsoever come its way, the bone, ossicles, even attic, even the dura, it can enter through and through. Cholesteatoma is just like a cyst, but it keep on enlarging. There is way whatsoever come its way, it erodes, it invades. So CSOM, it's etiquental type disease, which is mostly confined in the upper part of the middle ear, and it enters very easily into our middle ear. It can go into the middle cranial fossa. It can end up with the posterior cranial fossa and with very serious complications. So very commonly being asked question is, what are the complications of acute suppurative otitis media? What are the possible complications of chronic suppurative otitis media? So it may be asked in very different ways. Our ENT department, nose and ear, is in close proximity with the cranium. All infections inside the nose and the ear have direct access towards the middle ear because it's very next door, very thin walled. Here is the cribriform plate, here is the tegmen tympani, which can easily be traversed, especially a disease like cholesteatoma. So complications of ear infections will be asked again and again. And if a patient is coming to us with pyrexia of unknown origin, if patient is coming to us with a headache, persistent headache, mostly if it's localized somewhere, mostly it is localized at particular area, then easily we can trace the source of infection in 80 to 90% of these cases is either in the nose, paranasal sinuses, or most often in the middle ear. So infection in the middle ear for a few weeks is called acute suppurative otitis media. The germs are H. influenzae and pneumococcus. As the disease stays for a longer time, the bad and the worst germs, more notorious germs in the form of Pseudomonas aeruginosa, Bacteroides, Staph aureus, multiple germs simultaneously, concurrently at the same time starts colonizing the same. Now, rather than H. influenzae and pneumococcus, here are the Pseudomonas aeruginosa in the middle ear, and in the surrounding area are Bacteroides, are Klebsiella, are Staphylococcus, which are very difficult to get rid of, especially from this space, because posteriorly connected with the antrum, periantral cells, and here it can easily enter into the labyrinth, and through labyrinth towards petrous apex. Upwards is directly connected, is a tegmen tympani, very thin bone that connects, that divides, that separates the middle cranial fossa from the middle ear, that is called tegmen tympani. Posterior, its extension is tympani, can be easily traversed by germs, erosion in a long way, or if there's a cholestoma, they're more easily, cholestoma is the invading sort of complication of chronic suppurative otitis media in the middle ear. So we should focus here that infection, if stays for a few weeks, it's called acute suppurative otitis media. It is caused by different germs, H. influenzae and pneumococcus. If the disease stays for a longer time, it can be taken, the story of infection by the pus-forming organisms called Pseudomonas aeruginosa, Staphylococcus, or Bacteroides, which are extremely common. At the same time, more than one germ is colonizing, is causing the disease. In chronic suppurative otitis media, in tubotympanic type, the disease comes always from nose and paranasal sinuses. If we remove the source of infection from nose and sinuses, the disease usually in the middle ear is settled very easily. And if the disease is caused here in the attic region, attic is the uppermost part of the middle ear, or in the antrum posteriorly, it is either polyp formation, granulation formation, it is exactly over here. It may end up with the cholesteatoma formation, and this tumor-like lesion, this pathology certainly ends up with lot of destruction and erosions. And it is relatively a common situation because in chronic suppurative otitis media, mostly initially for a few years, there is no pain. There are only two classical symptoms in CSM, hearing loss and on and off ear discharge. Ear discharge is mostly foul smelling because of osteomyelitis and more so because of bacteroides. Bacteroides, anaerobic germs leads to total anaerobic situation and leading to foul smelling discharge. So infections here in the middle ear, in the acute suppurative otitis media and in chronic suppurative otitis media can end up with many complications. As a good students, now you should start thinking that most of the CNS infections, brain infections, 80 to 90% of the brain infections always take their origin from upper respiratory tract or the ears. From here, the ears are, if you find a patient of meningitis, brain abscess, any sort of cavernous sinus thrombosis, lateral sinus thrombosis, source of infection will be traced, will be nicely traced all over the body, but the main focus is in the ear and paranasal sinuses. That is a take-home message. Acute suppurative otitis media can end up with these complications. Chronic suppurative otitis media can end up with the same complications. Complication rate with acute suppurative otitis media with more and more improved antibiotics is far less. Complications with the CSOM, especially its atiquental variety, is getting more and more because symptoms are so mild. 1 year is fine, 1 year is discharging, patient is hearing very well, and the other ear which is succumbed to problem is not hearing, is the hearing loss, is the hearing discharge. Because 1 year is functioning very well, so people continue to have symptoms until otherwise there is serious complication of external or internal complications. So we like to go through how complications happen. So you can be put forward queries in a different way, how to investigate, how to treat, how to manage, as we were last time going through. Complications are the same. Acute sinusitis, acute rhinitis, acute rhinosinusitis, each end up with more or less the same complications. As you know, once you feel there's a deep-seated pain behind the eyes, and severe headache, nausea, vomiting, and the fever is going uphill, then certainly patient can have complications. Direct how infection reaches here. It is either through direct spread or through bloodstream or through already descent pathways. Here, how the disease reaches from the middle ear, the bone erosion, tegment tympani, then go directly. Venous channels, emissary veins connects the brain with the middle ear and various associated areas. Through blood, it can reach over there. Through dehiscent areas, few of us don't have the bony covering above on the top roof of the middle ear, only the dural lines. This is called dehiscence. Or infection can travel through round window, through erosion of oval window, through perilymph or endolymph. So infections from here can spread directly through erosion of this tegment tympani, can pass through this oval window or inferiorly placed round window, and infection can go through bloodstream, which are small channels here and there. It's a perforation of eardrum, and you can see very nicely the round window here. Complications are usually being discussed extracranial and intracranial. The most common complications, extracranial, temporal complications, extracranial complications are facial nerve paralysis, mastoiditis, various sorts of abscesses in and around the mastoid. Inside the mastoid, Bezold abscess, Lux abscess, Citelli's abscess. There's so many abscesses at the different parts of the ear can develop. And here, if the abscess goes along the sternomastoid muscle, that is called Bezold. If it comes at the top of the deep meatus, it's a Lux abscess. If it goes along the posterior belly of digastric, Citelli's abscess. So various abscesses, you will learn it, but the pus formation has gone so huge, so rampant, so extensive that it is breaching the walls of middle ear and going towards the muscles and their perimysium along that pathways. Infection can spread towards the petus apex. It is called Pulitzer abscess at the petus apex along the foramen of Lestrum, because the bone here is very spongy, is very thin. So from the middle ear, infection through deep petus part of temporal bone can end up towards the petus apex. Infection can go into the labyrinth, perilymph or endolymph, can end up with the game, fine function of the middle ear. All these are the known complications of acute and suppurative otitis media. So, bit by bit, you will start keeping in mind that the complications start after some time. Sometimes the first attack of acute suppurative otitis media is by so virulent, so detrimental strain of germs that within 2 or 3 days, patient mild earache and immediately developed meningitis, or facial paralysis, or mastoiditis, or mastoid abscess formation, or petus apex abscess, or petositis, or labyrinthitis. Any sort of complication can occur from as a result of acute suppurative otitis media or chronic suppurative otitis media. Among chronic, it's more common with atticoenteral type. Intracranial complications from the ear infections, how they go into the middle ear, into the middle cranial fossa or posterior cranial fossa. It is through direct spread, it is through blood, or it is through mystery veins or through preformed dehiscences, but it can lead to abscess outside the dura. Extradural abscess. It's the most common complication intracranially. Extradural abscesses sometimes continue to grow over here and sometimes from the sinuses over the forehead and forms multiple foci of elevations here. Then the outer table of cranium is totally necrosed, osteomyelitis happens, then many pod, puffy tumor, potato-like swellings here and there. These are pulpy masses. If just with a syringe get it out, it's a very thick pus. In acute phase, it is caused by H. influenzae and pneumococcus. In chronic phase, it's a foul smelling caused by Pseudomonas aeruginosa and anaerobic microorganisms. So my dear colleagues, we should focus on the ABC of intracranial complications in the form of extradural abscess, which is most common. Then lie the space called subdural abscess space. It is subdural empyema or subdural abscess can happen. It can end up with the brain abscess, which is very notorious and serious complications, having the maximum degree of morbidity and mortality happens because of brain abscesses, especially if the brain abscess is in the posterior cranial fossa. In the posterior cranial fossa, behind the tentorium cerebelli, then chances of morbidity, especially mortality, death rate is very high. And fourth complication intracranially is meningitis, pyogenic meningitis, tuberculous meningitis. Sometimes is a chronic phase specific infection in the form of tuberculous mastoiditis happens, and that is very notorious. That end up with direct spread everywhere with the multiple perforations in the eardrum. If you see multiple perforations in the eardrum, it's a diagnostic for tuberculous otitis media, tuberculous complications. And tuberculous meningitis is extremely notorious in the form of morbidity and mortality. It is very common disease, so we should know tuberculosis from various angles. Almost any organ in the human body can have impingement or trauma because of Mycobacterium tuberculosis. Sigmoid sinus thrombosis, lateral sinus thrombosis is another complication that can happen. It ends up with a fever, picket, fens pattern. Patient को rigors आते हैं, sweating होती है, for a while he is fine. Again after 2 to 3 hours, there is a fever. Then again there is bacteremia. Again patient develops fever and rigor. Again he is normal. So this typical pattern is sinus thrombosis, especially lateral sinus thrombosis. Transverse sinus and transverse sinus and sigmoid sinus makes lateral sinus thrombosis, lateral sinus and continuity thrombosis can lead to lateral sinus thrombosis. So lateral sinus is basically sigmoid and transverse sinus. Otitic hydrocephalus, that is a chronic complication of acute suppurative otitis media or chronic suppurative otitis media. The hypothesis is very clear. Once there is thrombosed sinus, we do have two lateral sinuses, one on the right, one on the left. It is usually said that the right side is usually bigger than the left lateral sinus. One is thrombosed, infected, and infection is controlled. It's get organized in the form of thrombus, in the form of granulations. Now there is no channel. It is full of new vessels and collagen fibers and various thrombus-like structure, but it's non-infective because you're sterilized with the help of antibiotics, injectable or oral. Then the drainage of the brain, especially the posterior cranial fossa, is jeopardized. Patients usually have fits of headache, the waves of headache, sometimes in the posterior, mostly in the posterior part of the head. And sometimes there's nausea and vomiting. Such particular type of diagnosis can be ascertained with a CT scan or MRI of the brain. The sinus is thrombosed in that particular pathology. So we'd like to just reiterate ABC. What are the many complications? Right now, we're just enumerating all the diseases, acute, chronic, and its complication will be repeated 2-3 times so that we know many words and how to treat that. Extradural abscess, which is most common, in many notorious ways, it can form Port-Puffy's tumor. Subdural abscess, also called subdural empyema, is usually localized initially. It is mostly localized in a particular area, either irritative symptoms or paralytic lesions. Either that area which is affected is paralyzed or usually having enough irritation or pain or usually fits. Brain abscess, that is the most notorious complication. That particular part of the brain is damaged and there is a fibrosis around that area. Longer is the duration of the abscess, more chances of formation of multiple loculi, multiple foci. It keeps on spreading in the adjacent part of the brain. Brain is semi-solid. It gives very easy access for the spread of infections. If infection is confined to the meninges only, that is called meningitis, especially the inner two meninges, which is called leptomeninx, infection is called meningitis. Pyogenic meningitis is very common, but bacterial infections, bacterial meningitis can also occur. Bacterial meningitis is having far more complications as compared to pyogenic. Lateral sinus thrombosis, which behaves like a typical fever picket venous pattern. Otitic hydrocephalus, that usually clinically represents in the form of headache, various episodes of headache, nausea, and vomiting. We were talking about extradural abscess. It is collection of pus between the dura and the bone, and very fine words that dura is split into fibrous layer and periosteal layer, where the blood pool is there. It's actually blood pool is thrombosed. It is most common seen in the posterior part. It can happen in the anterior cranial, middle cranial fossa, but this infection is certainly confined at a particular area initially, but if it's not treated at a far-flung area, it ends up with the formation of Port-Puffy tumor here, if it's nose and sinus inner region, and over the petus temporal bone, if it region is in the middle ear. Opening and evacuation of the middle cranial fossa through osteotomy, That is usually the standard part of the treatment. All these patient needs long-term follow-up. Meningitis, you know very well, there's a photophobia, there's neck stiffness, baby is usually hesitant to take diet, usually crying in episodes. There's a high degree of fever, there's a neck stiffness, they're the very characteristic symptoms, normal. There's a classical picture, lumbar puncture, sometimes is being done, but most often in pyogenic meningitis, usually it's not. Third generation cephalosporins within few days can totally settle the situation. The treatment is medical treatment is very straightforward. Third generation cephalosporin, intravenous, patient always needs admission and kept in intensive care setup. All patients with intracranial complications should be hospitalized, should be kept in intensive care setup, as they are really in not good shape. Subdural abscess collection between dura and the pia mater, and not between dura and arachnoid mater. It is the most dangerous complication. It can spread all over the surface of the brain. Then it's called subdural empyema. The patient can present with the paralytic or irritative lesions. It is nicely controlled. If you just control the synapse, the source of infection, the patient will be very fine. Source of infection, my friends, will be always somewhere in the nose or somewhere in the ear. But very rarely, you can't, in 10% patients, you may not get any source here. Brain abscess, temporal lobe is the most, temporal lobe followed by parietal lobe are the most common places to harbor, to have these abscesses. Clinical features are really headache, nausea, vomiting, then visual issues, diplopia, papilledema can appear later on. Lateral sinus thrombosis. If sigmoid sinus and transverse sinus is infected and there is a pyogenic thrombus formation, episodes of lot of germs grow inside the bloodstream. Bacteremia, septicemia, pyemia, and presents absolutely in a typical way of waves of rigor and fever and sweat that leads to picket fence pattern. Otitic hydrocephalus, patient presents with episodes of headache because of thrombosis of lateral sinus. That has happened long ago. Patient has episodes of headache, and usually everything is normal except raised CSF pressure, because dominant part side of the ear, usually the right side, lateral sinus is totally not transmitting any blood. Exit of blood from the brain outside the cranium is not possible. The headache episodes are more when there's more activity, when there's more blood in the brain. How we will investigate? If we asked in exam or anywhere, how you will diagnose your case, how you will investigate. We'll start with a very innocent and simple storytelling that I'll take precise clinical history. I'll do clinical examination. I will go for the relevant lab tests. That particular test, an MRI, as and when required. Neurological tests now are available like EEG, electroencephalography, electroneuronography, how you will manage the patient. Certainly, as a patient is having complication, general status of health is totally jeopardized, is at risk, will admit the patient. We will hospitalize the patient. That should be our first statement. Will hospitalize, will keep the patient in intensive care, will take IV line, will give mega doses of antibiotic therapy. In acute suppurative otitis media, our selection is very simple. We follow CDC, Communicable Disease Control, headed by WHO. Every year, there's a very good line, good outlines, and good outlines are on the basis of outline of antibiotic selection is on the basis of culture and sensitivity reports. Culture and And we'll always say that we use multi-department treatment, multi-discipline treatment. Now, in such cases, a patient is having ear infection, patient is semi-conscious, patient is having nausea and vomiting, patient is unable to walk, patient is having diplopia, patient will